Okay. Thanks for allowing me to share a few cases of renal hemosiderosis. This turned into pulling several cases from Mayo to kind of do a little bit of the analysis to see where all the deposition is throughout the kidney. So kind of just as a background, hemosiderosis is just a rare cause of acute kidney injury from iron overload. Typically, it arises from the setting of chronic intravascular hemolysis, and the etiologies are usually associated with paroxysmal nocturnal hemoglobinuria, valvular heart disease, prosthetic valve replacement is one of the most common causes. Then red blood cell disorders, including sickle cell disease and hereditary spherocytosis. So for the pathophysiology, what happens is you have this lysis of red blood cells. They start to release the hemoglobin, and then these free hemoglobin dimers will start to bind to haptoglobin. And then these complexes will eventually bind to CD168, and then they'll get engulfed into the mononuclear cells, and then they'll be broken down by hemoxygenase 1. However, if that threshold is met, where you have too much hemoglobin relative to the haptoglobin, that free hemoglobin will start getting filtered into the glomerulus, and then it gets taken up by the proximal tubular epithelial cells, and then that goes into the lysozymes. And ultimately, you get this acute tubular injury. But the exact mechanism isn't really known, and there's a few ideas of it just being a combination of both lipid peroxidation and oxidative stress, as well as heme cytotoxicity and iron cytotoxicity. So for renal hemosiderosis, you might see on a biopsy, you might see these brown pigments within the tubular epithelial cells, and it's commonly seen as in association with acute tubular injury. And then if you add in any kind of iron stain, example here is Prussian blue, that's positive. So then classic finding, then you move on to EM, and you'll see these features of acute tubular injury. So you might see your loss of microvilli, you might see some degenerative changes, you might see some enlarged, deranged mitochondria, you might see some vacuolization, and then you'll see these deposits of iron within the lysosomes. But if you go back and look at all of the case reports that they have, in terms of where the deposition is, it makes sense. It's all in the proximal tubules, but very few people have actually reported where other deposits are at. So one report talks about it's inconspicuous glomerular epithelial cells with a little bit of dusting on iron stain. And then another case talks about on EM within the podocyte foot processes, just some few electron dense deposits. So there really isn't really anything going on in the rest of the cell or the rest of the kidney. So as we started pulling these cases, one of the questions we started to come up with is we were looking at the slides, there's iron kind of everywhere. And so we wanted to know, like, what is the distribution of this iron? And then also if there's any kind of injury that's associated with the iron. And if that's outside of the proximal tubular epithelial cells. So what we did was we did a case series from the Mayo cases. And in the end, we have 5 cases that were signed out as renal hemosiderosis. 5 of those, or 2 of those, one was a TMA and one was an IgA nephropathy. And then we started looking for any kind of acute tubular injury. Was it present or not? Makes sense that it would be. And then we started looking for iron deposition all throughout the kidney, by light microscopy and by EM. Things that we were looking at are where in the glomeruli. And so this is where the EM comes in, this is where we start narrowing that down. Are they in the podocytes? Are they in the mesangium, capillaries, or endothelial, or even in the basement membrane? Are they in the basement and Bowman's capsule and those parietal epithelial cells? Are they in the proximal tubules? If they are, which we are expecting, are they also involving the distal tubules? Are they in the loop of Henle? Or in addition, like where else in the kidney? Is it in the cortex? We all know it's there, but is it also going to spread over into the medulla? And then also the overall extent of hemosiderin. So finally, we looked at mononuclear cells, and then we're looking for any kind of finding that might suggest any kind of injury, so any kind of vacuolization, any kind of deposit, mitochondrial issues, and trying to see if there's injury elsewhere within the renal parenchyma. So here's an example of 3 of the different cases, and you can see the spectrum that was reported by the pathologist. This first one, the extent to the hemosiderosis was only at 10%. This was actually signed out as focal hemosiderosis. But on eye microscopy, there were several patchy areas of hemosiderin deposition, and then also on higher magnification, you could see deposits throughout the several of the different tubular epithelial cells. But if you go into 30%, it seems a little bit low, although there was like one section that has cortex. I think that number was kind of dropped down because you have a little bit more of the medulla in there. And then finally, on a higher extent of hemosiderosis, you see that about 60% is what we called it. So to walk you through some of the deposits that we were looking at, I'll walk you through a few different cases. And so the first case is a 63-year-old male. He had hypertension and obesity and developed these flu-like symptoms following influenza and pneumococcal vaccines. His initial workup was significant for anemia. He had a hemoglobin of 7.7 and some thrombocytopenia. He was started on steroids and sent home, and then he came back to the ED after his symptoms improved, and this is about a week later. He presented with acute kidney injury. His serum creatinine was 11, and he had a nephrotic range proteinuria, and then his complements were low. He did have a positive SSA, but he didn't have any kind of features of scleroderma. And his serum ferritin was normal. So we started on hemodialysis simplex, and then also started an eculizumab. An atypical HUS gene panel was reported as equivocal. However, there was homozygous for a variant of unknown significance. So here's what the light microscopy features show. So there's a lot of this features of TMA, pretty apparent. So glomeruli with some endocapillary hypercellularity, there's some mesangiolisis, and then on higher power, there's some areas of basement membrane and double contours. For the vasculature, you see the intima, that's all edematous and have a mucoid change. And then there are areas where there are occlusion with fragmented red blood cells within vessels. And then if you look around at H&E, tubules have some iron deposition or brown pigments, and then some of these additional cells kind of in the Bowman's capsule were showing this pigment as well. And then on iron stain, you can see the extent of this iron deposition. You can even see it over in the parietal epithelial cells. You can see it in the tubules. And then if you look more closely, there's something kind of going on in the glomeruli. So are they in the podocytes or the other cells? That's where the EM comes in. So for the EM, you can see these features of TMA, this subendothelial lucency. For the podocytes, there's a little bit of iron deposition. There is within the capillary leaves, you'll see some foam cells. They are taking on a little bit of those iron deposits. And then for the podocytes, they're going to have these iron deposits. There's some areas where there's some foot process effacement. And then in the mesangium, you start to see these deposits within the mesangial cells. And then on lower power, you can see here some parietal epithelial cells containing the iron deposits. Here they are again on higher magnification. When we zoom in a little bit more, you can see the deposits. You can see kind of these blown up mitochondria. And then in some of the mitochondria, you can actually find a few of those deposits. Tubules, I should expect tubular injury, and then some iron deposits. More higher, and then kind of this is like looking like as a tangential of one of those vessels, and you can see the foam cells within the vessels. But right here along this vessel wall, we're kind of getting that tangential cut. So it's parasites of the vessel are containing iron deposits. So in terms of the follow-up for this patient, he remained oliguric, went home and unexpectedly died about 3 months later. There was no really understanding what caused his atypical HUS. So the second case is a 79-year-old male with hypertension, coronary artery disease, and then he had child rheumatic fever with mitral valve prolapse. He was status post mitral valve repair 10 years prior to his presentation, and when he presented with CKD. He had a serum creatinine of 1.5. He had episodic hemoglobinuria and hematuria, and then his other labs were normal. So this is the extent of the hemosiderosis that we saw. We call this 70% of the specimen, and then about 80% of those proximal tubules were also involved. So these brown pigments also showing up on your Prussian blue. But if you start looking around, there's cells within the interstitium. Here's the glomerulus. Podocytes also have, or we'll say glomerular cells at this point, have some deposits. For the EM, there might be some deposits in the subendothelial space, or maybe even endothelial cells. Some deposits in the basement membrane. We're kind of approaching maybe mesangium right there. Here's some podocytes again with the deposits. Also notice that there's this podocyte foot process effacement here and here. Some more basement membrane deposits. More deposits in the podocytes here. Some of them have a lot of vacuolization, some injury. And then the mesangium, more deposits here, paramesangial space. And then also more mesangial cells containing these deposits. And then in this capillary loop, you can see just kind of this free iron deposits kind of right in the lumen. In the interstitium, you can see some fibroblasts containing deposits. Here's a little bit more of the interstitium, some more of these iron deposits. Tubules, so you can see them in the lysosomes. So for follow-up, the patient ended up having severe mitral regurgitation based on their history. So the echo also showed this left ventricular outflow tract obstruction. So they ended up doing a septomyomectomy and a CABG. And then his most recent serum creatinine is 1.3. This is a serum creatinine from about 2 years ago. The case was from 2017. So this serum creatinine is roughly maintained it's the same. And then from our, just some additional images from the cohort of the cases. Again, more mesangial deposits. Maybe, maybe even basement membrane deposits. Mesangial. You see these parietal epithelial cells. Yeah. So the distribution that we saw from here, obviously there's going to be acute tubular injury on my microscopy. And then the proximal tubules are going to be involved as well. But there's a wide range. I mean, there's proximal tubule and extent of only 5%. And this is kind of a very mild case. This is the one case that was called focal hemosiderosis. But then it also involved the medulla in that case. But that was more macrophages that we were able to see. Additionally, there were some cases where the proximal tubular extent was extremely high. So that was 80 to 90%. And in those cases, it did start to extend over into the distal tubules. And then it also involved the loop of Henle. So most of those, again, also involved the cortex. But when they were really extensive, then they kind of spilled over into the medulla. So for the distribution of the iron deposits on EM, we saw that most of these cases ended up having deposits in the mesangium, no matter how extensive those iron deposition was, it was also present in this one case that had very little iron deposits. Also for the podocytes, when that iron load was really, really high, it showed up more in the podocytes. And then it also showed up kind of still lower into the interstitial cells. When it was extremely high, this AKI with the TMA and then this mitral valve repair, the two cases that I showed you, they started to show up in kind of vascular cells, so parasite, glomerular, endothelial cells. So those are where we started to see this. So kind of linking those back to what we know, at least in the lab, and kind of making this more translational. For podocytes, there is a mouse model out there that has shown that podocytes, when they endocytose hemoglobin, is through a megalin-cubulin receptor system that causes this oxidative stress. And so this decreased expression results for nephrin and synaptopodin. And then we see these podocyte cross-effacement and podocyte apoptosis. And these mice end up developing proteinuria. So this kind of brings up the topic of that. The proteinuria might actually be not just low molecular weight. In this case, with a podocyte damage, you might have possibly a high molecular weight proteinuria. For mesangial cells, we know that there's a significant hemoglobin exposure that is thought to activate proliferation of the mesangial cells, and then they start laying down matrix. And this is through the heme oxygenase 1 pathway. And that, what it does is it has an effect on regulation of P21, the cyclin kinase. And for interstitial fibroblasts, the oxidative stress activates these fibroblasts to overproduce matrix proteins. We didn't really see a whole lot of interstitial in these cases. At most, it was only 5%, and that was in a transplant case. And then for endothelial cells, free hemoglobin, when it enters into that subendothelial space, you have this redox process where you get this ferrous state, and that ends up resulting in endothelial dysfunction and a pathological vascular remodeling. So, in conclusion, obviously we're going to have deposits within the proximal tubular epithelial cells. We're going to have acute tubular injury. But we also have this, when there's a very mild hemosiderosis, it's still going to be present elsewhere outside of the tubules. The big thing is that we saw it with macrophage uptake. We can also see it in mesangial cells. And then there's also this, when you have this concomitant diagnosis, whether it be like a TMA, we also saw an IgN, that has resulted in kind of this higher burden of iron. And so we see this involving about 80% of those proximal tubules. And then when you have this really high iron burden, you end up seeing kind of this downstream effect. It's kind of like light chain proximal tubulopathy or like a lysozyme-associated nephropathy, where it starts to not just involve the proximal tubules. You'll start to see distal tubules, and in this case, you'll also start to see the loop involved. And then you also start to see an increase in fibroblasts that are involved. And then in very, very rare occasions, you might see focal areas of involvement of endothelial cells or vascular cells. But we think of this also as a very endothelial damaging process, but we're not really seeing a whole lot of that effect on light microscopy or EM. And then also the glomerular deposition is not rare. As I mentioned, it's mainly plenty of times we've seen it in the mesangium. And then you see this increased iron burden, and it shows uptake in the podocytes, parietal cells, epithelial cells, and these are all showing features of toxic cellularity. So I think the big thing here is that these findings are suggesting that hemosiderosis can extend beyond the proximal tubules, particularly in the severe or chronic disease, and then a more diffuse pattern of iron toxicity is shown here than we've been previously appreciated. I do have another case if you guys want to see that comes from our cohort, and this is more along the differential. So just a background for this case: 77-year-old male, history of mechanical aortic valve prosthesis. He's a longtime warfarin user, and he has acute on chronic CKD presenting with some proteinuria. I'll just tell you what it was. It was signed out as an IgA nephropathy. There was obviously these acute tubular injury with these brown cytoplasmic deposits. You can see them here. But then on the iron stain, there's something else there, and it's still brown. So what will be your differential here?
Lipofuscin.
Okay. Well, wouldn't the myoglobin also be iron positive? Maybe bile too. We did a bile is negative. You can see here a mixture of these different cells or deposits. And then also in this kind of peritubular capillary, I don't know if you can see it if it projects very well, but you can see some deposits here along the peritubular capillaries. So we thought this was a little bit along the lines of the lipofuscin.
Yeah.
So Belle went back and she did some scoping so that we could at least show that there is some substructure for the lipofuscin. And so I really appreciate her helping out with that case. So I just want to thank everybody for allowing us to share these cases, and then with the support of everybody who's been going with her and working on this project.